So take a second and look at this photo. It's a little disorienting when you first look at it. Most people will look at this and say, "What's going on here?" Take a look at this video. This is me trying to orient my thumb in the fashion that you just saw in the photo. So that's normal old me, not having fantastic mobility, but kind of normal mobility. Now let's go back to that photo again. So you see what that person can do? That, my friend, is a manifestation clinically of hypermobility. A second photo here. Look at how far this individual can bend their knuckles back or their MCP joints backwards. It's quite a bit of range of motion. And once again, here's my lame attempt at bringing my metacarpals into extension. Doesn't go back very far. What is hypermobility and how do we treat it? That's what we're going to talk about today on the Angry Physio. So, a few points about hypermobility to start. Point number one, when I'm talking about hypermobility, I'm really talking about what I would refer to as diffuse hypermobility, meaning people that have hypermobility or extensibility in their joints that's above normal values and in a lot of joints, not just one joint. People can get hypermobility in one joint due to environmental factors, such as if somebody, for example, sprains their ankle, has an inversion sprain, rolls it. The ligaments on the outside of the ankle get stretched out. They are like the plastic that surrounds a six pack, in that when those ligaments stretch out, they don't really go back to their original shape. So one could argue that that ankle is now hypermobile because of the sprain. Point number two, diffuse hypermobility tends to affect females quite a bit more than it tends to affect males. Depending on where you look, the prevalence of this in the population is about 4%, but of those 4% of people who are really diffusely affected in all their joints, disproportionate number of those people are women. Let's move on to point number 3. So when people with diffuse hypermobility are children, a lot of the time when they're children or teenagers, they're not really in a lot of pain, but it's pretty evident that they have it by the way that they look and the way that they move. When these people hit adulthood, that's really when the pain hits. And the annoying thing and the thing that makes it difficult to treat is that the pain can be all over the place, not just in your joints, but in the tendons, in the muscles. There can be trigger points and tender points in the muscles. There can be myofascial pain. The myofascia is just a layer of connective tissue that kind of goes all over the body. So this makes it difficult to treat indeed. So before we get into the exercise demonstrations that I tend to use in my clinic for patients with hypermobility, I just wanted to really quickly show you this review, and I'll put it up here on the screen. So if you want to really like dive deep into this and really get a good idea about the totality of hypermobility disorders, give this a read. And just to go over a few quick points on this, there is a diagnosis or a syndrome called Ehlers-Danlos syndrome. And this is a soft tissue connective disorder where there is a big association with a lot of hypermobility. Sometimes other organ systems can be involved, but if you are hypermobile, not a bad idea to go talk to your doctor and just get a definitive diagnosis. Now, in terms of diagnosis and self diagnosis, I'm going to put up here on the screen. There is a 5-part questionnaire. I'm putting it right up here. If you look at the top part of this here, there are 5 questions. So if you read those questions and you answer yes to most or all of those, I would definitely say that since that questionnaire has a pretty good sensitivity and specificity, that there's a good chance that you have a hypermobility disorder, and all the more reason to go talk to the doctor. Now, in conclusion, here, if you look at this, is the conclusion of the article. The approach to treating hypermobility is multimodal or multidisciplinary. And the person who wrote this article really thinks that doing stabilization exercise with a physical therapist is a good idea. But also, let's not forget that some people that have hypermobility disorder, it's very exhausting. And referral to a mental health specialist may not be a bad idea because chronic pain is a bitch to deal with. Now, I would also say seeing a doctor such as a PM&R or a physical medicine and rehab, otherwise known as a physiatrist, is not a bad idea because they can get on board in terms of the pharmacology and other interventions. So now let's take a look at a bunch of stabilization exercises to get the ball rolling. All right, so first we have a bucket of plastic particulates. You could use a 5 pound bag of rice for this, but for my hypermobile people, all that I'm doing with them is having them put their hand inside the bucket and kind of go through the middle part of the range, opening and closing the hand, not going to a full fist and not hyperextending the fingers. Good way or a good adage or a good way of thinking about doing these things is to work the muscles kind of in the middle of the joint ranges, not at the extremes. Secondly, here I have a gyrotonic exercise ball. You can get those on Amazon. They're not expensive and they're fantastic. And what I'm doing right there is I am revving it up and using my wrist flexors and extensors to stabilize. Here, what I'm doing is an isometric core exercise. Now, you may have remembered from the conclusion that we saw before that isometric is good. I'm locking my abs in. I'm kind of keeping my lower back from flipping up off of the mat, keeping it nice and steady. And I'm separating diagonals out. One arm and the opposite leg are going out and back. And that is way more difficult than you think. So, a good core isometric exercise. Next, I've got what we would call a compound movement or two exercises in one. I'm kind of doing like a lat pull down there with the cables. And at the same time, I'm engaging my glutes and kind of squeezing my butt as I do a partial lift. Once again, I'm not going up into an extreme position here. I'm just kind of going about 2/3, 3/4 of the way. So a butt bridge with a lat pull down. So if you have a cable machine, that's a nice exercise. Here, I am stirring the pot. This is once again an isometric exercise where I am putting my core, my abdominals into one position and doing things with my hands, like going up and down while I'm holding the rubber band. And you can do this to each direction. Here's one of my sentimental favorites. I call this a knees to elbow plank. So I am planking on my side with my knees touching the mat and my elbow touching the mat. Now I can just isometrically hold it like that. Or if I want to make it more difficult, I can lift my arm and leg and do it that way. Here's another one I just saw the other week, which I like. I'm holding a kettlebell, so I'm forcing my abs to stabilize and my spinal extensors to stabilize. Then I've got a rubber band around my feet, and I am lifting one foot up, so I'm challenging my abs and my hip flexors and just trying to hold that isometrically at the top while I'm stabilizing the weight with my hand. So it's attacking a lot of muscles at the same time. And lastly, here, I am kneeling on a Bosu, and notice I'm trying to keep my toes off of the floor. So just being in that position is going to be a little bit of a challenge. And I am taking a ball and I'm just moving it around in diagonal motions and forcing my core to react to it. So this is just a quick little swath of exercises. There are tons of things that you can do, but think, keep it in the middle of the range and keep it isometric. Thanks for watching.